Hi, I'm Brian Mandel, the editor-in-chief of the Cleveland Clinic Journal of Medicine, CCJM. Welcome to Beyond the Pages, CCJM podcast, where we will take you in depth into the content of selected articles from the Cleveland Clinic Journal of Medicine and explore a few interesting tangents along the way. Through moderated interviews with our authors and other experts in the field, we hope the clinicians will gain a more nuanced perspective of clinical concepts that are changing the practice of medicine and be able to apply this perspective to the care of our patients.
Welcome back to part 2 of our conversation. Please be sure to listen to part 1 of this episode. Let's get back beyond the pages. So speaking of CPAP, we talked about kind of this intervention of CPAP. Can we kind of tell listeners like what exactly that is? I mean, what people put on their face or their nose and kind of walk through that, what that looks like?
I remember my mentor in Michigan would say, when in doubt, pressurize the snout. So this is what CPAP is, essentially, to pressurize the snout. That's not what I tell my patients. So usually what I tell them, it's a little bit like a bicycle tire. You're inflating it. You're trying to splint the airway open by putting some pressure there that should overcome the forces that collapse the airway. And that's how it works. And Dr. Kaminsky is right. It's completely agnostic as to where the location of the narrowing is. CPAP will work and dilate the airway at different airways, places of collapse. And it is effective if we can make it comfortable.
I had the opportunity 2 weeks ago. I was at a sleep surgery meeting, and the keynote speaker was Colin Sullivan, who was the inventor of CPAP.
Oh, cool. Okay.
So that was a great thrill to be able to hear his journey as to trying to figure this out, and how at the beginning it was poo-pooed quite a bit, and now it's the staple.
Yes.
So can you tell us there's settings on the CPAP, like how is that? Is there kind of a standard protocol, like start with this setting and then kind of work your way around it? How do you go through that?
Oh, that's a great question. So if you go through a home sleep apnea test with the idea of never stepping in a lab and just having all your treatment and testing done outside a lab, then the home sleep apnea test is done, confirmed sleep apnea. You have a choice of an auto CPAP, self-adjusting machine. So the machine, through different mechanisms, flow oscillometry, it can detect whether the airway is narrow or open, and therefore can ramp up the pressure or back off on the pressure. So if the patient is in a deep stage of sleep or on their back and the airway is completely collapsed because the muscles are so relaxed or because the tongue is pushing backward, the machine will detect this obstruction and ramp up the pressure to open up the airway. And if the patient is on the side in a lighter stage of sleep and the airway is completely open, the machine during the same night will realize that and back off on the pressure, and it does that through the night. The only problem with that is that we sometimes allow the events to occur if we set the pressure too low, the range of pressure too low, and we let the machine respond to that. And sometimes it takes a little bit of a lag before the machine can detect that. So these residual events can be consequential. So it becomes a skill to look at the downloads. The machine actually will report averages over the past 30 nights. It will report details over the preceding nights. So you can look at details and determine if that's the case and adjust the settings to prevent these events.
So I think one of the things I hear a lot is people's kind of fear of what's it going to be like wearing one of these things, sleep. I'll never be able to sleep with one of these things on my face. So how do you go about, I guess, adjusting for comfort, and what are the options and if the patient doesn't feel like they can handle it?
That's a great question. It is, I know people are apprehensive. Sometimes they come in because they've heard of other people telling them either that this was a terrible experience or that this was a great experience. So they're coming to you with their with an impression that's flavored by what they've heard. What we do know is that we're seeing more recent studies showing an adherence, a long-term adherence at the year of 70%, which is in more recent studies. So 70% of patients who start CPAP will still be on it after a year, and compared to 50% a few years ago. So there's something we're doing that's improving the adherence. And I think it has to do with the technology, it has to do with the masks, it has to do with the interfaces that they use, the plastic they use, the fitting. So the machines are quieter, they're not as noisy, the masks are more comfortable. So there are things we can tell our patients that, give it a try, because I think it can change your life and can do that quickly.
So yeah, tell me what you see in terms of real life outcomes from at least the patients who respond to CPAP. What kind of difference are we looking at in terms of lifestyle?
So we can think of this in two ways. What are the short-term outcomes and the long-term outcomes? The short terms are the things that the patient will realize right away. The sleepiness that's not there anymore, the car accidents that don't occur, because that's a big thing. The alertness, the mental acuity, they will tell you that. I've had patients, those are the minority, get out of their titration study where they've been put on CPAP and that was titrated during the night, and they come out and they see me and say, "Doc, that was the best night I've ever had in 20 years. I got a brain transplant." This is not the majority of patients who do that with one night. It usually takes a little while for them to get there. But we have patients who this is a dramatic and highly impactful intervention. And it's important not to avoid using CPAP if there's immediate discomfort. I've had patients who took them a year or more of trying different masks and adapting to it before they finally realized this really works for me. And they realized that sometimes when the electricity goes off and they have spent a night without the machine, and then they have the sudden realization, oh my God, this has really worked for me. And it's convincing to them.
I think it's really easy in the patients who are symptomatic.
Yes.
And that's probably about half the patients who are truly symptomatic and tired. But the more difficult patient are the patients who have severe sleep apnea and they have no symptoms. They're not tired during the day, and so they don't get any self-reinforcement by using CPAP, other than maybe their bed partner doesn't hear snoring. But that is a more challenging population, I think.
That's very, very true. It's very interesting because we learn as physicians to ask some questions we know work. So one of the predictor of somebody who's not going to do well with CPAP is if he's here because the spouse told them to. Okay? So they're not vested in there. They feel like they've been dragged here against their will.
Wow.
And we make a point of asking, because if that's the case, we want to tell them up front that this does work, and give it a try, and maybe pay more attention to them.
And I think it's hard to get across to patients the true rationale, because my patients are concerned about snoring. We could talk about rates of recurrent atrial fibrillation or stroke, hard to manage hypertension. But what they basically want to know is, will my snoring be taken care of? And
that's what they're hearing, that's what they're seeing.
That's the most important thing to them, even after we've had these more in-depth discussions.
I was surprised to hear you just said 50% are symptomatic. I thought it'd be higher than that. So 50% are feel fatigued? Is that what you're saying? The diagnosis of obstructive sleep apnea?
That would have an abnormal Epworth Sleepiness Scale score.
Oh, okay. Wow, that's interesting. Okay.
I think that was a study out of Pittsburgh.
Wow. Okay, I thought it'd be higher than that. That would be difficult to. I imagine more difficult to convince somebody to wear this.
And I think the other thing, at least what I notice, is that there is not a direct correlation between sleepiness and severity of obstructive sleep apnea. You can have somebody with a mild obstructive sleep apnea who is terribly tired and gets tremendous benefit from CPAP. And then you have people who are the worst of the worst. They're truck drivers. They're like, I got to get on the road. I can't use a CPAP, and they're not tired at all.
Wow. Okay. So one thing I think people ask about a lot, probably because they see it on TV, before we get to surgery, I wanted to ask this question is, what about oral appliances? What do we know about them? Are they useful? Is it worth trying?
So oral appliances, I think, fit into the alternative therapy group. I think we all agree that CPAP is the first line therapy. I think it's that's what gets offered, that's, I think, just something that is hard to disagree with. If people can't tolerate CPAP, or if they just will not try CPAP, because although the adherence rate may be 70%, that's of people who have a prescription. Not everybody who gets a prescription for CPAP actually fills the prescription. So that's a big issue. So oral appliances they're like an upper and lower retainer. They should be custom made, and they're fit in such a way that they're connected, and that pulls your lower jaw forward. That pulls the tongue forward, opens up the retrolingual airway, and there are connections through the palatopharyngeal arches that pull the soft palate forward as well. So it can take care of snoring. It can take care of mild to moderate sleep apnea, less so severe sleep apnea, but there is a success rate. There is no such thing as a free lunch. It is not without its issues. Some people, if you have temporomandibular joint dysfunction, it can cause some myofascial pain in the area, and some people just cannot tolerate that very well. The pressure that it puts on teeth can cause some shifting of the teeth and shifting of the bite. People are given a wedge in the morning to bite down on to ease their jaw back into position so that their bite goes back into position in the morning. There are over-the-counter ones, and there are ones made by professional dentists. And there's an American Academy of Dental Sleep Medicine who certify dentists in making these. So there are studies out there that show that custom-made appliances are more successful than over-the-counter. You just can't get a boil and bite device over-the-counter and expect that to work.
So are mostly people getting oral appliances for snoring or actually going after obstructive sleep apnea, or is it kind of a mixture?
Both. If you get it for snoring, that's not covered by insurance.
Oh, okay.
If you're going for treatment of obstructive sleep apnea, it is covered by medical insurance.
Okay. So now maybe we can walk through like the patient who's being evaluated for potential surgical intervention. So is this a patient who's been offered CPAP and maybe fails CPAP, or what kind of happens to get them to be evaluated by surgery?
Yeah, it's a very, very rare patient who has not tried CPAP, or who we don't force to try CPAP before offering some sort of evaluation for surgery. So if they have tried CPAP and it has not been successful for the variety of reasons that people are not successful with CPAP, they have difficulty keeping it on. There's lots of patients who I see who wake up and it's on the floor. They don't remember taking it off, and they can't change that behavior, so it's hard to get them to keep that on. Some people are claustrophobic. They can't wear a mask. Some people have skin reactions, and there's ways to try and go around that, whether they want to do that or whether they're successful with that. You can get aerophagia from some patients. Just the pressure is, filling the GI tract, and so they're belching or the other end, making some noise, and they don't enjoy that. So, of course, my patient population is skewed because I see a lot of the failures. So that's not to say that everybody is having these problems with CPAP. But if they do have a trial of CPAP and it's just not successful, and they can't use a dental device, then the evaluation includes the anatomy that we talked about before. Do they have a deviated septum, enlarged turbinates? Sometimes they're just mouth breathers. And if we correct that, if they fail medical management and we perform a septoplasty and reduce their turbinates and give them a good nasal airway, we can convert a non-CPAP user to a CPAP user. That also could lower the pressure. There's a study that showed it can lower about 2 centimeters of water pressure in order to make it more comfortable for the patient. So there are plenty of patients who we do surgery, but it's not typical sleep surgery. It's nasal surgery in order to allow them to be successful with CPAP. If that's not the issue, then we take a look at their airway. What is their jaw size? That's the container, and the tongue has to fit in that container. And if the jaw's too small, it's going to push the tongue back. Some people need to have that container enlarged and undergo bony jaw surgery, maxillomandibular advancement, usually performed by an oral surgeon. Sometimes some plastic surgeons do this. It's a big surgery. Not too many of my patients are willing to go through it, but that has a success rate of about 85 or 90%, independent of BMI. Many of our other surgeries are dependent on a BMI less than 40 or less than 35. And so we then look at the tongue, look at the tonsils, and try and get an idea of some kind of approach to take for surgical evaluation, further surgical evaluation, or actual surgery.
I was surprised to learn more about the potentially taking some of the tongue out. Can you tell me about that?
So a midline partial glossectomy.
Yeah, that one.
Yeah. So this is somebody who has too much tongue, and if you debulk the tongue in the center towards the back, in some cases, you can get more room. I think that was a surgery that was done more prior to other surgeries coming online, such as hypoglossal nerve stimulation or even hyomandibular suspension.
Can we walk us through those two options as well?
Yeah, sure. So traditionally, uvulopalato-pharyngoplasty has been the mainstay since the early 80s. So for the past 40 plus years, there's been this soft tissue surgery where you remove the tonsils. Initially, you would trim the back of the soft palate, take off 1 centimeter or 2. That has a lot of patient dissatisfaction, wasn't very successful. It morphed into more of a throat lift rather than excision over the years, but still success rates were not as high as we would want them to be. 9 years ago, hypoglossal nerve stimulation got FDA approval. This was work that in 2014, the FDA cleared it. But that work on hypoglossal nerve stimulation had been going on since the 80s in animals, and it took a very, very long time. Hypoglossal nerve stimulation is essentially a pacemaker for the tongue. So we place a stimulation electrode cuff around a portion of the hypoglossal nerve. And this is the portion that stimulates the protrusors, the part of the nerve that topographically reaches the muscles of the tongue, which stiffen and protrude the tongue. We also place a sensor between the ribs in order to know when in the breathing cycle this should fire. And then there is a pacemaker-like device that is placed in the upper chest. And at night, when the patient is sleeping, at each breath, it fires and it stiffens the tongue and brings it forward. So that success rate surgically is about 75 or 80%.
Wow.
But not everybody's a candidate. Not everybody's a candidate.
If you walk me through that, no way that works. Wow.
It actually does.
Wow, that's impressive. That's really incredible. Okay. So who's the candidate for this? What's the workup involved with a hypoglossal nerve stimulator?
So the criteria put forth by the FDA are adults 18 and above. There are some pediatric indications just approved for teenagers with Down syndrome. My partners do that. I work with adults, but for an adult, 18 and above, your apnea-hypopnea index right now needs to be between 15 and 65. The FDA has actually raised the upper limit to an AHI of 100. And not all the insurance companies have followed suit. I think there's only 2 insurance companies who have raised it. Medicare has not at this point, but we expect at some point the upper limit will be 100, which essentially means there's no limit because that's most of the people who have obstructive sleep apnea. The body mass index needs to be 35 or less. The FDA has also increased this to a BMI of 40. That is probably going to be a little bit more of a challenge. We may not be as successful in treating these patients with elevated BMIs. It is untested territory because we've been restricted up to this point. So even though they increased the upper BMI limit, we don't have a good experience of patients between a BMI of 35 and 40 and how that's going to work out. Prior to 2017, you were not able to get an MRI scan. Now you have conditional approval for an MRI scan as well, so you can get head-to-toe MRI scans with a 1.5 Tesla magnet. So that's not a restriction anymore. It shouldn't be for anybody who's pregnant or planning to get pregnant. If they fulfill all of these criteria and have had a good trial of CPAP and have failed, then the next step would be going to the operating room where we do drug-induced sleep endoscopy. The acronym is DICE. We sedate the patient to try and mimic natural sleep. We place a scope, a nasopharyngoscope, into the nose to take a look at how the palate, the soft palate, is collapsing. It has to collapse in a flat fashion, not a circumferential fashion, in order for the patient to be a candidate. And if that's good and it collapses in the right way, then we have a discussion, and once we get insurance approval, the next step is surgery.
Wow, and what's the procedure like? I mean, how long does it take in general?
The surgery is outpatient surgery under general anesthesia. It takes about an hour and a half to do. Patients go home. We don't prescribe narcotics when they go home. They take Motrin, Tylenol. They're sore, but they're not so sore that they need some sort of narcotic to cover the pain. It heals in for about a month, and then in partnership with my colleagues over in the sleep center, we have the patients follow up with the folks over in the sleep center, and they activate the device and adjust it. It's adjustable. And we get them to where we think clinically they're doing great, and then we test again with a sleep study to make sure that we're at the right setting and the patient is doing well.
Okay, this has been a whirlwind tour of obstructive sleep apnea. I want to thank both of you for coming in, Dr. Boussaint and Dr. Kaminsky. This has been fantastic. I learned a great deal. Thank you so much for your times.
Great, thanks for having us.
Thank you. Great. I had a lot of fun.
All right.
Thank you for your insights in helping us to go beyond the pages of the Cleveland Clinic Journal of Medicine. To read CCJM articles, visit ccjm.org. To participate in other accredited educational activities, visit ccfcme.org. You can subscribe to the podcast on Google Play, Spotify, or however you prefer to access your podcasts.